So I'm Chris Meduri. I'm an interventional cardiologist at the Piedmont Heart Institute and Marcus Heart Valve Center in Atlanta, Georgia. So stroke and TAVR is a really interesting topic. When the technology really came out in the first few years, there was a really strong concern that the risk of stroke was significantly higher in the TAVR arm versus surgical patients. And we saw this in the first randomized trial, Partner A trial. And initially we thought that the reason behind this was some of the way the technology was developed and kind of an early experience with operators. Because of this, I think a lot of people have reacted by, in a good sense, have now changed the way the technology works and the delivery systems to reduce those risks. And physicians are even more aware of how we can reduce that by technical things we're doing differently during the procedure. And what we've seen since then in registry data really across Europe and in the US and in the high risk and extreme risk core valve trials is that actually stroke rate is at least the same as surgery and actually may be lower than surgical procedures instead. So it's actually really important because it was initially, I think, a concern about the TAVR technology, but it looks like going forward, we don't have to worry that we're going to be worse than stroke. And so it's a good thing for patients downstream as well. The other really interesting thing we're seeing now as we start to really study this after our initial concerns about the stroke risk is what is actually happening. We know that about 2 or 3% of patients will have clinical strokes at 30 days, but what we didn't recognize is that there's a lot of subclinical things happening as well. If you actually look at all patients and you actually do a diffusion-weighted MRI, about 80% of patients have new brain lesions on MRI, just the majority of them are not clinically picked up or count as a major stroke. And one potential issue with this is, me as an interventionalist seeing these patients afterwards, we don't see strokes. We're happy, we're high-fiving that there's no major injury, but we may be unaware that we're causing more problems we may recognize downstream. And these things could be delayed memory, cognition issues downstream that maybe weren't picked up. So now I think in the field we're trying to find out new ways we can prevent these things from happening. And they really hover around the procedural period and after the procedure. During the procedure, we're now trying to really make sure we're appropriately anticoagulating these patients sufficiently. That really hovers with ACTs around 250 to 300 at least. And then there's been a big push for these embolic protection devices. There's recently some trials that came out at EuroPCR in Europe looking at actually capturing debris as well as deflecting debris that would be coming by putting devices across the arch. And these things have really shown small surrogate benefits of markers, really no huge hard clinical endpoints. But I think it's encouraging to see maybe it'll cut down some of that debris. The challenge is how important is that actually happening on a clinical level. Lastly, the other part we're really learning about is what we should be doing after the procedure. We know that half of the strokes in hospital happen actually after the procedure and the day after in to 72 hours. And then for that first 3 months, there really is an increased risk of stroke as well. So how do we do antiplatelet therapy, anticoagulation? Currently, people without any history of atrial fibrillation will just be on dual antiplatelet therapy, aspirin and Plavix, for usually about 6 months. What we're learning is that we probably need to make sure if anybody has a history of AFib or even has a brief episode of new onset AFib in the hospital, they should be on oral anticoagulation therapy for at least 6 months to a year. And those patients really, they should be on Coumadin, I believe, because we don't really have any strong data with the other anticoagulation agents. The last really thing I'd comment on is we talked about dual antiplatelet therapy, but there was a recent meta-analysis coming out of Europe that showed that there was actually maybe just as much benefit just using aspirin alone instead of clopidogrel and aspirin. And we've got to really see where that data is going to go forward. There's a ART study that's coming out of Canada primarily that's going to help answer that question. I know they've finished enrollment. Hopefully next year or two we'll have some more answers about the importance of these things.